Hello, my name is David Brown, and for Penn State University's STAT 507 course in epidemiology, I will be presenting on the surveillance of antimicrobial resistant pathogens and their role in healthcare associated infections. As modern medicine has progressed, numerous invasive techniques like the use of catheters and ventilators have been developed to treat patients. While these procedures improve quality of care and save lives, their invasive nature provides an avenue for the entry of harmful pathogens. When an infection arises as a result of clinical care, it is known as a healthcare associated infection, or HAI. The Center for Disease Control monitors four common HAIs: central line associated bloodstream infections, catheter associated urinary tract infections, surgical site infections, and ventilator associated pneumonia. Despite detailed guidelines to control HAIs, extensive efforts on the part of healthcare providers, and the attention of the U.S. Department of Health and Human Services, healthcare-associated infections remain a threat to the safety of those being treated in a medical setting. According to the CDC, about 3% of hospitalized patients in a 2015 survey had at least one HAI. This translates to approximately 687,000 HAIs in U.S. acute care hospitals in 2015. About 72,000 of these patients died while hospitalized. In addition to worsened patient outcomes, HAIs come with direct costs to the medical system that total an estimated $10 billion per year. The threat of healthcare-associated infections becomes much larger when coupled with the relatively recent emergence of antimicrobial resistant pathogens. Sometimes called superbugs in popular media, these pathogens are resistant to treatment from antimicrobial medicines like antibiotics, which have served as a pillar of modern medicine since the discovery of penicillin a generation ago. Without effective treatment, these pathogens can prolong hospital stays, increase morbidity and mortality, and spread to others in a healthcare setting above and beyond what is typical of other infections. If antimicrobial resistance continues to grow, medical treatments like organ transplant, chemotherapy, diabetes management, and surgery could all become very high-risk procedures. AMR pathogens exist in every country, and the CDC monitors dozens. But in this presentation, we will focus on three that are of great concern and commonly associated with HAIs. CRE, sometimes referred to as nightmare bacteria because of its resistance to nearly all available antibiotics, methicillin-resistant staph, better known as MRSA, and multiple drug-resistant P. aeruginosa, which I'll refer to as MDR-PA. While any patient who enters a hospital and receives an invasive procedure is at risk for a healthcare-associated infection, there are several factors that increase the risk. Patient characteristics such as age or underlying conditions that compromise the immune system. The elderly and immunocompromised are overrepresented in HAI cases. The amount of time the patient is exposed to the possibility of infection through an invasive intervention. For example, the risk of catheter-associated UTI increases the longer the catheter is in place. Complications from the intervention, such as surgery that proceeded longer than expected, and finally, unsanitary practices by healthcare staff, such as not properly washing hands or mishandling of medical waste. These unsafe practices allow pathogens to persist by facilitating their transfer between patients. These risk factors are general to HAIs. The risk of antimicrobial resistant HAIs specifically grows as the fraction of the pathogens resistant to treatment grows. The emergence of antimicrobial resistance has been linked to the overuse of antibiotics, both in the medical and agricultural industries. While still in widespread use, efforts have been made in recent years to rein in overuse and slow the growth of antimicrobial resistant pathogens. But the chemical arms race between pharmaceutical researchers and the pathogens will continue. In this presentation, I will seek to answer three surveillance questions related to antimicrobial resistant HAIs. First, how has the incidence of antimicrobial resistant HAIs changed over time? Second, what pathogens contribute most to the total observed incidence? And third, is the incidence dependent on the type of HAI, and is this consistent across pathogens? For example, are there more catheter-associated UTIs or surgical site infections in MRSA? To answer these questions, I turn to the Center for Disease Control, which has created a data portal called the Patient Safety Atlas, based on data gathered from the National Healthcare Safety Network in the years 2011 through 2014. The NHSN is the nation's most widely used HAI tracking system with over 25,000 participating medical facilities. It is an internet-based system where information is entered by healthcare staff on a quarterly basis, with standardization of what should be reported as an HAI. Reported events include the previously mentioned HAI categories. While ventilator-associated pneumonia is included in the data, this analysis will not consider it as data is limited for certain years. Facilities that report to the NHSH are numerous in scope, but the bulk come from three sources: acute care hospitals, long-term acute care hospitals, and inpatient rehabilitation facilities. In addition to the three pathogens considered in this analysis, there are 28 other drug bug profiles reported, with stratification of the data available based on geography, age, year, and event type. Our first surveillance question is how the incidence of antimicrobial resistant HAIs has changed over time. Using data from the Patient Safety Atlas, we track the time course of our three pathogens, CRE, MRSA, and MDRPA. From 2011 to 2012, and 2012 to 2013, there is a clear increase in all three pathogens, especially in the increase in MRSA from 2011 to 2012. However, the incidence in 2014 decreased for all three, perhaps because of efforts by healthcare facilities in reducing the incidence of HAIs in patients under their care. Surveillance data in subsequent years will determine if this was a temporary reduction or the start of a larger trend in the fight against HAIs. Our second surveillance question is which pathogens contribute most to the incidence of antimicrobial resistant HAIs. Again, using data from the Patient Safety Atlas, we plot the number of infections from our three considered pathogens for 2011 through 2014. The white bar represents the total number of HAIs for that pathogen, irrespective of resistance, while the blue bar shows the portion of the HAIs that are resistant to antimicrobials. We can see that by far, MRSA contributes the most towards the incidence of antimicrobial resistant HAIs with over 20,000 infections. This represents nearly half of all staph infections that were tested for resistance. Of greater concern, however, is the incidence of enterobac HAIs. While only 3.5% of these HAIs are CRE cases, that is, they tested positive for resistance to all antibiotics, the potential threat looms large because of the large incidence of this particular pathogen. If the percentage of antimicrobial resistance grows to be on par with that of staph, it could present a serious threat to public health, explaining why CRE is of great concern to the CDC and sometimes referred to as nightmare bacteria, even though the incidence of MRSA is currently much higher. Our third and final surveillance question is to determine if the incidence of antimicrobial resistant HAIs is dependent on the type of HAI and if this is consistent between pathogen types. To answer this, we present the cross-tabulation of our three considered pathogens and our three considered HAI types for 2011 through 2014. We can note from this chart that not only does incidence vary by HAI type, with surgical site infections being the biggest contributor, but the ratios also differ by individual pathogens. MDRPA and CRE infections are most likely to be associated with catheter UTIs and least likely to be associated with surgical site infections. MRSA, on the other hand, shows the exact opposite pattern. Understanding the relationship between pathogen and intervention type could be of importance for developing pathogen-specific best practices during these interventions that reduce the incidence of HAIs. While the CDC PSA is a trusted data source with large sample sizes, there are some key limitations. One limitation is that there are no standardized procedures for determining that a pathogen is indeed resistant to treatment, which leaves a potential for different interpretations of antimicrobial resistance across healthcare facilities. Another limitation is that the reported mandates and regulations vary by state, meaning that some states may have lower participation and reporting rates. This has the potential to make state-by-state comparisons misleading. And as with any survey, there is the possibility for bias and misrepresentation by those doing the reporting. The exploration of this topic includes the antimicrobial resistant healthcare associated infections are indeed a present threat to public health. This threat has the potential to increase as antimicrobial resistance becomes more widespread as pathogens continue to evolve. Trend in antimicrobial resistant HAIs over time suggests temporary reduction in incidence has been achieved, but the CDC needs to continually monitor these metrics and provide guidelines to help healthcare providers avoid HAIs and the overuse of antibiotics. It appears that MRSA is the most common threat today, with most cases coming from infections associated with surgeries. However, CRE should probably be of greater concern. If resistance here begins to rise, it could lead to a far greater incidence of CRE because of how common the bacteria is in healthcare-associated infections. There appears to be a relationship between pathogen and HAI type. This kind of information could be used to inform best practices geared specifically to intervention type in the healthcare setting. And finally, there is a need for researchers to develop new antimicrobial therapies. The rate at which resistance has grown since the widespread introduction of antimicrobials is sobering. If trends continue without the development of new treatments, public health will likely suffer. Thank you for listening. I hope you have found this presentation informative and interesting. Provided here is a list of the main web pages used for information and data in this presentation, all of which have extensive subheadings that may interest the